Hi, everyone. Welcome to today's webinar on the metabolic connection, the link between heart and metabolic health. We'll just give it about a minute to let you guys come in and get settled and get ready for a wonderful presentation by the amazing Dr. Silverman. I'll read his bio, although sometimes I know some of you may know him and he may not need an introduction, but we'll just let you guys filter in. And then we'll get started here in another minute or so. But just heads up on this, the plan for today is that we'll go through about 50 or 60 minutes of discussion and presentation, and then we'll leave time for about 15, 20 minutes of Q&A. So it will be a longer session today, but definitely ask your questions because it will be recorded and it will be up on our website and emailed out within about 48 hours. Please put your questions into the Q&A box, not the chat. That way we can more easily identify the questions and it just helps us to stay on task with it. So definitely put your questions in and we will go through those. Even if you have to hop off early, it will be recorded and you'll be able to go back and listen later. So all right, well, let's go ahead and get started. I'm very excited and have the pleasure of introducing our speaker today, Dr. Robert Silverman, who is a distinguished chiropractic physician, certified clinical nutritionist, and an internationally recognized speaker with a reputation for being at the forefront of functional and integrative healthcare. He is the founder and CEO of the Westchester Integrative Health Center, where he blends evidence-based chiropractic care with advanced nutritional science to drive optimal patient outcomes. He has authored not one, but two Amazon #1 best-selling titles, Immune Reboot and Inside Out Health, and serves on the advisory board for the Functional Medicine University. He hosts the Proven Health Alternatives podcast, a top-ranked show where he explores cutting-edge topics with leading experts in health and wellness. And with that, I will turn it over to you, Dr. Silverman, and I'll let you take it away.
Thanks so much. I'm excited to be here. There's the inaugural webinar that we're going to do with Microbiome Labs. There'll be a few others coming up. I look forward to seeing you, and hearing from you today and in the future. Please do ask the questions. I think that's where the most key takeaways will be shared in that give and take between the colleagues and myself. I look forward to those. I encourage those. I've got a lot of great help here also. So that said, I'm going to be going over the different slides, 60 minutes or so, no more than that. I've got some help. I've got some notes over here that I'll be going back and forth, so we'll make it a little bit more live. And let's dig in about the idea of the metabolic connection, the link between the heart and metabolic health. I'm going to attempt to shed light on the profound interplay between metabolic dysfunction and cardiovascular disease. I will emphasize that these conditions rarely exist in isolation. This session, I hope, will explore how insulin resistance, visceral adiposity, systemic inflammation, and impaired lipid metabolism collectively drive both metabolic syndrome and cardiovascular pathology. Hopefully, you will be able to, after listening to me for 60 to 90 minutes, recognize overlapping clinical patterns, utilize advanced functional testing, and apply integrative strategies, including targeted nutrition, micronutrient repletion, personalized lifestyle protocols to optimize cardiometabolic resistance and prevent disease progression. Those were my thoughts last night, my goals, because I didn't have a slide of goals or objectives. Ocean Robbins once said, when you eat the standard American diet, you get the standard American diseases. No diet is worse than the standard American diet. Look at the acronym SAD. So when people come into my office and I do practice, interestingly enough, people say, my diet's done this. Remember, the standard American diet is basement bottom diet. Anything you do that's different than that, you'll get improvements. But the question is, did you optimize your time? Did you optimize your outcome? Did you individualize and personalize that diet for that specific patient? And that's what I try and tell everybody, that my goal is, and I'm sure this is resonating with everybody already, the idea of N = 1. So I'm an Arnold guy. I thought I will he made a couple of great points. I went to a talk that he gave, and he talked about motivation. And I think we as doctors need to be motivated ourselves, but more so that we need to be able to motivate the people in front of us, i.e., those being patients. So the idea of motivation is you have to have a vision. So my vision is I want to create health for future generations starting now. Don't think small, think big. I appreciate the fact that my podcast is growing, but why can't I be bigger than Huberman? Why can't I be number one? I don't want to think micro. I want to think macro. Ignore the naysayers. Yeah, I'm sure everybody here can relate to that naysayer idea. Why did you do this and why did you do that? Let's stick with Western medicine, which there's nothing wrong with, but ignore the naysayers. Work your butt off. Yep, I was up to about 12 o'clock last night working, but it wasn't work. It was fun. It was preparation. It was learning. It's my mission. It's my mantra, if you will. Just don't give back something back. I wholeheartedly agree with that statement. I try and give at least 1 to 2 scholarship sessions, or I guess it would be better described as case sessions per month. People who just can't afford it, but they need their health. I mean, everybody needs their health, but they have no means of changing their outcome without help. I'll give you a real quick story. I don't want to waste, I don't want to take up too much time. There was a person, a woman, she was a single mom who had 3 children. She had an awful issue of IBS. She didn't want to be in a workplace because she had to use a laboratory literally every hour. So we're able to help her and everything like that. All 3 children are going to school on scholarship. Some are academic, some are athletic, none of which would have had the time to be able to go to school because they, at the time that she had this IBS, were supporting the house. So, that's, in my mind, giving something back. So basics in extending health span. We know in the idea of longevity, there's lifespan and there's health span. Lifespan is how long you live. Health span is how long you live and you are what we would refer to as healthy, non-chronic disease. Decrease the consumption of ultra-processed food. Ultra-processed foods, 53% of the calories is from ultra-processed. Here's a couple of analogies, if you will, or statements that people have made. Jack LaLanne, Dr. Jack LaLanne, he was a chiropractor, once said, "If man makes it, I won't eat it." I've asked some other people, could you describe your diet? And they said single in nutrients made from nature. Heard Andrew Huberman make a great line. He said, if it walked on the earth, it had a heartbeat, or it was grown in the ground without glyphosate, it's good. Eat phytonutrients, eat from the color rainbow. The more phytonutrients we have, the better chance we have of getting antioxidants in our body. So interesting when it comes to phytonutrients, eat from the rainbow, if you will. A good friend of mine has said that. So for instance, obviously we'll say berries are a great choice for a fruit. Don't eat blueberries every day. Eat blueberries one day, eat raspberries one day, eat blackberry one day, because you're going to get different phytonutrients, even though you're in the berry family. Switch it up, same with apples, etc. Eat the right kinds of protein. Straight up, if you're going to eat protein, you're going to eat animal protein. If you're going to eat plant protein, you need to take leucine. 2.5 to 3 grams of leucine with a plant protein will make as effective as animal protein. So again, animal protein over plant protein. However, plant protein equal to animal protein if you take the branched chain amino acid leucine. Eat the right kinds of fat. Well, what are the right kinds of fats? Well, obviously trans fats are out, they're X'd. Really the right kinds of fat. I'm big on polyunsaturated, monounsaturated. It's not a limitation of saturated fats, but it's not at the top of the list. Optimize your diet. You are what you eat. You've heard that before. Food, good food, is a potentiator for health information. Bad food is a potentiator for inflammation. Choose wisely. Daily exercise. I try and get it every day something, even if it's a recovery day. I try and get a walk in, get on the treadmill if the weather is not appropriate outside. Brain health. Well, it's really gut health to brain health. Whatever you do to your gut, you do to your brain. Whatever you do to your brain, you do to your gut. They're bidirectional. Brain gut is the conversation piece of the last 5 to 6 years. but clearly brain health where you want to decrease that incidence of neurodegenerative disease. So here's some of my longevity hacks. Number one, nutrition. You've heard this before. Let food be your medicine. Let medicine be your food. Hippocrates got it right without question. Dramatically reduce sugar, starch, and your ultra-processed food intake. If you're going to eat sugar and starch, eat a lower amount. We have a slide speaking to the timing of when you should eat your carbohydrates. Exercise, incorporate resistance training. Muscle mass is a longevity organ. Dr. Gabriella Lyons said that. I like to say that muscle mass is the currency of longevity. Resistance training, both men and women need it. Resistance training, it can be body weight, it could be bands, it can be kettlebells, it can be dumbbells, it can be barbells. If you saw my social media story, Dr. Robert Silverman, you'll notice that yesterday I was using a barbell off the ground and I got some love on my story for social media. My wife took a picture because she thought it was hysterical that I was breaking my buttocks to get some resistance training in. Sleep, it's when your brain really recovers. Your brain goes to about 40% of the size at night. It's like a sponge squeezing out metabolic waste. So sleep is a critical add. Health detectables, tracking. So for instance, I would look at the Aura Ring. I found one of the most effective tracking devices was the continuous glucose monitor. I mean, first of all, you know that you're being charted. You're going to watch what you eat. And two, you will find your individuality. A great example of that is that I found out that if I consume brown rice versus toasted coconut, obviously 99% of you would say brown rice would raise your glycemic index, your blood sugar more. Not on this guy. It was toasted coconut. Lifestyle mindset, health is wealth. Share that with your patients. Intermittent fasting. I'm a big proponent of intermittent fasting. So let me give you a couple of takeaways on intermittent fasting. I believe in intermittent fasting 12 to 16 hours. 18 hours, you're getting into a little stress area. Women who are of menstruating age, we'll call it, I don't know, 12 to 52, if you will. So that 40-year, 4-decade portion of their life, they need to intermittent fast a little different than men. So if I'm doing 16 and 8, 16, the first number being the amount of time that you are fasting, feeding is 8-hour time. My suggestion with a woman is for the first 2 weeks of her menstrual cycle, 16 and 8 work, take it down to 14 and 10, week 3. Week 4, take it down to 12 and 12. Progesterone's big in the last 2 weeks, estrogen to progesterone. When progesterone's high, any kind of strain or stress to the body knocks progesterone down. Intermittent fasting is a bit of a stress. When progesterone goes down, the PMS, it's real. So that's my suggestion to really optimize intermittent fasting. My suggestion for intermittent fasting is don't eat for the first hour that you wake up and don't eat 3 hours before you go to sleep and you'll get there. Breath work. So a couple of real keys with breath work. Our body's designed to release 70% of its toxins through breathing. Interestingly enough, you want to breathe through your nose and not your mouth. 84% of the weight that you lose, you will get broken down to CO2. That'll be expelled in the air. So good quality breath work is a critical add. Purpose, mission, and community. Kind of like what Arnold said, your vision, give back. Happy that we're here. Happy you took time to listen to me today. Hormesis, well, sauna. I'm a big proponent of sauna. It improves body circulation and decreases blood pressure, decreases inflammation and oxidative stress. Everybody always asks how long, 19 minutes or less. Everybody always asks how often, 2 to 3 times per week, decreases cardiovascular issues, 27%. 5 times a week, 50% and 54% actually decrease in cardiovascular, 19 minutes or less. It should be a far infrared sauna. That far infrared sauna should be between 146 and 174 degrees. 200 degrees with a covering like a Finnish sauna damages the blood-brain barrier. Call it a no bueno. Supplements, we're going to go over those. We're going to come away with what I like to refer to as the dynamic duo. I'm a big proponent of testing and not guessing. How do I know without taking a test? And of course, I'm a big proponent of low-level laser, not just red light therapy, but low-level laser therapy. If you have any questions on that, put that in the Q&A. I can't control everything in my life, but I can control what I put in my body. Your biggest source of toxins will come from the food that you eat. Number two will be the air that you breathe. Thomas Jefferson ate only as a condiment to vegetables, which constitute my principal diet. He ate meat. So basically, he had the Tom Brady diet before Tom Brady even was a thought, in that he ate about 80% plants and 20% protein, a diet that I generally like. So what's the problem? Number one, sugar consumption. The average American consumes 160 pounds of sugar per year. Sugar works in the reward center of the brain. When mice were studied and offered sugar versus cocaine, 94% of mice took sugar versus the cocaine. Sugar is extremely ruinous to our overall health. Wheat consumption, look, real simple. 146 pounds is too much. No gluten. Minimize your wheat. Wheat also is very detrimental to one's gut. Not only that, it is essentially very high in the glycemic index. So no sugar, no wheat, caloric sweeteners. The average American consumes 142 pounds of caloric sweetener per year. Caloric sweeteners can be more detrimental to your health than sugar, in that they can increase your incidence of leaky gut, and without question, they damage and pierce the blood-brain barrier. Many of them are neurotoxins. So no caloric sweeteners. There's been, since 2012, tremendous rise in diabetes, parallel rise between diabetes and weight gain. Diabetes. Dr. Mark Hyman coined that portmanteau phrase. Joint pain, back pain, osteoarthritis, 8 out of 10 Americans can have lower back pain at some point. Everybody knows that I'm a chiropractor. Osteoarthritis is misled in that people think it's just wear and tear. It's osteoarthritis, like rheumatoid arthritis, is an autoimmune condition. 80% of the people that get autoimmune condition are females. NSAIDs, non-steroid anti-inflammatories, they do decrease pain, but they impair healing. Nutraceuticals, like we're going to talk about, decrease pain and promote healing. Which do you prefer? We live in a very medicated world. We take more medications than any other country or any other two countries combined. Toxics and stress. We live in a toxic, stressful world. Some people may say that I look like I was stressing out 15 minutes before I was just getting into game shape for the webinar. And lastly, it has been stated that by the year 2030, 50% of the adult population in America will have at least one symptomology of neurodegenerative disease. So I call this a wow. Dietary sugar increase of 100 grams a day, 400 calories, is linked to a 28% higher prevalence of depression. How the sugar industry shifted the blame to fat. Wow. This is worth a moment. In 1966, Harvard University, 3 researchers studied the idea of sugar versus fat. In that they said sugar was okay and fat wasn't good. 2016, in JAMA Internal Medicine, 50 years after they said the world was flat, it came out that these 3 researchers were paid by the sugar companies to lie. So they told us the world was flat 9 years after 2016. Now, there are still people who believe that fat is the enemy and sugar is the goddess. And that is not necessarily the case. Remember, they told us the world was flat, and we found out they lied about it. And those 3 people, and the basic premise is sugar is the backbone of the larger amount of cholesterol being laid down. Sugar is without question deleterious to one's overall health. We should limit our intake of sugar. U.S. obesity rates have tripled over the last 55 years. Morbid obesity has risen tenfold. We are just getting heavier and heavier and heavier as a country. So insulin resistance. Now, if I had to do one test, and I know I've been a little slow with the slides, I'll pick up the pace a little bit. Insulin resistance, or insulin levels, blood sugar to insulin levels, would be something I would test for. Insulin resistance is pro-inflammatory. It damages arteries. It has an adverse effect on the central nervous system. It definitely leads to PCOS and metabolic issues. We live in Farmageddon. Farmageddon started in 1985 when Nutrition companies were allowed to advertise. In 1997, they were allowed to neglect to put up their side effects, etc. So the idea of Farmageddon, we are 4.4, let me try that again, 4.24% of the world's population. We use 52% of the world's medications and 80% of the world's pain medications. We are a drug-laden country. So what's the problem? Well, antibiotics are a problem. I'm not anti-antibiotic. I hope that's not a misnomer, but the bulk of the antibiotics are really coming through our food, our livestock, about 80%. That's 29 million pounds, which equates to 270 million prescriptions per year in humans. The CDC says conservatively 30% of antibiotic prescriptions are unnecessary. Over 50% of hospital patients receive antibiotics. It was stated that during COVID, which is a viral infection, 52% of people come to the hospital were given antibiotics before they had a positive COVID test. Antibiotics are, without question, the nuclear weapon to the gut. They deplete your microbes, calcium, magnesium, B vitamins, and vitamin K. So as I said, let's talk about some blood sugar hacks. If you ate the same amount of food, but you eat it in this order, look what will happen. Vegetables and fiber first, protein and fat second, sugar and starch third. You will decrease your glucose spike by 73% and reduce your insulin spike by 48%, just eating in a different order. So I don't count calories. I count when you eat the calorie. Much more important. I don't count calories. I count chemicals. I don't count calories. I count satiety. I don't count chemicals. I count nutrient value. I think you guys get the point. A couple other hacks: apple cider vinegar in the morning, tablespoon with water to start the day, great choice. If you can get a 10-minute walk after meals, you'll have a twofold benefit. Number one, obviously your blood sugar will go down. Number two, 3 meals times 10, 30-minute walk per day. And no naked carbs. The old idea of adding a protein, a fat, or a fiber to carb, kind of like an apple with almond butter, really works well. The takeaway to this slide is this: very simply, less than 7% of Americans are metabolically healthy. Less than 7%. So that means if you go to an office and you have 25 patients in a day, two people are metabolically healthy. So without question, not having metabolic health, obviously, they're probably going to follow with dyslipidemia, something to look at and test for in virtually everybody. But the question is, and I ask all my patients, what do you have to lose by eating healthier? The premise of eating healthier is people think eating healthier means that the food won't taste as good, which we all know is not true. So why doesn't an old healthcare model work? Well, real simple. The primary driver of chronic disease is the interaction among genes, activities of daily living, and the environment. So the functional medicine, many of you have seen this. I think it's a beautiful picture. Looks for the root cause. Symptoms lead us to systems, which enable us to look for root cause. Root cause resolution can be found by proper diagnostic skills, or if you will, precision medicine. So root cause, you can see what the tree has, you can see the branches, you can see the leaves, but you can't see what's in the soil. That is getting at the root cause, which is the genetics, nutrient deficiencies, etc. Cardiometabolic conditions that have cardiovascular metabolic factors: stroke, diabetes, heart disease, non-alcoholic fatty liver. One of the number one reasons for non-alcoholic fatty liver, the overconsumption of fructose. One in three adults have metabolic syndrome. Basically, in America, there's 114 Americans estimated that have metabolic syndrome. So if you had a practice just specialize in metabolic syndrome, you would be busy. So here we have the components of metabolic syndrome. If you have 3 out of 5 of these, you have metabolic syndrome. Elevated waist circumference, over 40 with a man, over 35 with a non-pregnant woman. Elevated triglycerides, over 150. Reduced HCl-C, 40 in men, 50 in women. Women have higher HDL because of estrogen. Blood pressure, these numbers always seem to change, but in this particular one, it's 130 over 85. An elevated fasting glucose, anything over 100. I would say anything over 90, I would be real concerned about. So the diagnosis of metabolic syndrome, basically a new type of diagnosis, new type of markers. We have our hypertension, we have our kidney functions, we have dyslipidemia, of course, obesity. Everybody who comes in my office gets an in-body, a body composition with visceral fat test, hyperinsulinemia, and too high in uric acid. Metabolic syndrome, risk factors, diagnosis, management with natural approaches. So here's a good takeaway. Natural foods have great potential therapeutics in the management of metabolic syndrome. No surprise to anybody. Subjects that have metabolic syndrome, more risk of type 2 diabetes, cardiovascular disease, lifestyle. It's all about lifestyle. It was mentioned that I have a podcast. I can tell you that every different type of health practitioner, not just functional medicine, health practitioner at some point has a lifestyle hack or a lifestyle implementation. Lifestyle is very broad. It's definitely a funnel, but without question, lifestyle really plays an important role in the progression of numerous risk factors of metabolic syndrome or the quelling of those risk factors. And there's metabolic abnormalities that are characterized by insulin resistance, activated macrophages, etc. So some risk factors of cardiometabolic risk factors. You're looking at non-alcoholic fatty liver, CKD, cardiovascular disease, glycemic control. High blood pressure is a risk factor. High blood cholesterol, and we'll get into the details. It's not just total cholesterol. It's going to be the particle sizes, ApoB, lipo, LP little a, things of that nature. High triglyceride levels, which I think is an underrated marker. I think we should give more credence to that. Smoking, I mean, that takes 14 years off your life. I think that's enough said. Physical inactivity, everybody get moving. Just please get moving. Diabetes and pre-diabetes. Overweight and obesity, 75% of Americans are overweight or obese. Obviously, that's 3/4. Poor sleep, we need about 7.5 hours of good quality sleep. I think only 20% of Americans get that. Unmanaged stress, excessive alcohol intake, and poor diet. Here it is, test and don't guess. So we test and don't guess to get a baseline. So therefore, we can look and try and find the blind spots with some extra testing, if you will. Early detection is critical. Most people don't get tested until disease is already causing a problem. Early detection of biochemical markers allows for early intervention and ability to prevent disease. 50% of heart attacks, you've all heard this, have standard lipid profile the day of the heart attack. Heart disease is the leading cause of death for both men and women, and this is the case not only in the US, but worldwide. It's one of those "are you kidding me's." We just said heart disease leading cause of death in the US for the past half century. 49% of Americans on an American Heart Association test signified and identified heart disease as the #1 killer. More than half still don't know it. The question was posed, why? I took this quote. This is worth reading. People may not want to acknowledge heart disease. It's leading cause of death because many risk factors for heart disease require lifestyle modifications that are hard to do, such as stopping smoking, consuming a heart-healthy diet, and losing weight. Lifestyle, change of habit, lifestyle. ApoB, it is virtually sinful if people test for cholesterol markers and don't test for ApoB. There will be a slide coming up. Basically, ApoB is the Titanic. The three different types of demographic on the Titanic at that time will be VLDL, particle size LDL, and LP little a. So let's go through some importance. ApoB is the single best predictive heart attack on a cholesterol marker test. Every particle of dangerous cholesterol is wrapped around ApoB. Unfortunately, less than 5% of Americans have been tested for this. This is an issue. Put this down. This is on my longevity test list, ApoB. So why direct LDL? I just got a new patient and it was indirect LDL. Long story short, you want to direct LDL because there's a 20% difference in accuracy between indirect and direct LDL. Why would you want to estimate something that can cause damage? Why wouldn't you want to know a precise number? So that's the key takeaway. The risk is in the LDL particle size. It's not just in the number of the particles. So a low risk is having a large pattern A. You see they're big and they're fluffy, the LDLs. The higher risk is the smaller LDL. So they may weigh the same, but you may have small particles. Why? Well, if you think about it, think of your artery wall like a carpet on the floor. The small guys can get under the carpet and start plaquing from inside the arterial wall, whereas the large one are on the outside of the arterial wall, and they can make a tremendous change with natural approaches with those large LDL pattern A's. LP little a, this is your heart attack marker. This can affect up to 25% of the population. If you have it, 40% of your relatives have it. So obviously you need to test your relatives. It's a sticky lipid. Basically, it glues things together. The bottom line is 1% of the population tests for the genetic marker LP little a. So cardiovascular disease remains the world's top killer. Major study, this was measuring the number of bad cholesterol carriers, specifically particles containing ApoB, which offers a much clearer prediction of heart disease risk rather than traditional cholesterol tests. Study also highlighted overlooked importance of lipo-A, a genetically inherited lipid that can sharply elevate risk in some individuals. With easy and affordable blood tests for ApoB and lipo-A now available, a revolution in heart screening could be within reach. The insurances that I use, I should say, and the labs I use, do cover these markers. So remember, we talked a little bit about the three types of bad cholesterol lipoprotein carriers, all contain apo particles, a defining structural feature. So we have number one, VLDL, very low dense lipoproteins, LDL, which is really the particle size, LDLs, and lipo or LP little a. So these are the three. Remember, the big ship, small little demographics within the ship. ApoB is the first one you should test for out of those four. Statins increase LP little a, an inconvenient truth that needs attention. So I have seen, and the data hasn't changed yet, but the data will change. I have seen in my office and in many of my colleagues' offices this drastic change in LPA markers, sizes. They've come down dramatically. There's been a tremendous declivity approaching LP little a with natural approaches in their numbers. Statin use was associated with a 52% increased prevalence of calcified coronary plaque compared to non-users. Let me see if I have enough time for another story. Yeah, interesting. I was on a plane. I was going down to Nashville to do a talk for offered alternatives to cardiologists to heart care. Yeah, so it was obviously something similar to what we're talking about now. And the gentleman next to me, not knowing that I was a functional medicine chiropractor, was lambasting the idea of having a natural person. It was just his opinion there. But the bottom line was when we talked about the calcium score, his calcium score is like 1,500. He had been on statins for about 30 years. And I asked him retrospectively, could you look me in the eye and tell me, did you think that that was the answer? He's like, no. If I knew then what I knew now, I would know that I would watch my lifestyle and use the statins more judiciously. So, little story. New statin guidelines. Everyone 40 to 75 should be considered for drug therapy. My answer is statins have important side effects, which are sometimes underreported by Big Pharma. Ultimately, humans are not predestined to have a heart attack in middle age, as populations worldwide have shown. Let's first, in most instances, not all, but most, consider everyone eligible for a therapeutic lifestyle program. Statins increase the risk of diabetes. We've heard that before. They help cause, if you will. I hate to say it like that. The first heart attack stopped the second one. Look, drugs have their place. I am not anti-drug. Drugs have their place. I believe that we would dramatically decrease our drug consumption in America if we adhered to more therapeutic lifestyle changes and a more salubrious health program. High sensitive C-reactive protein, that is a heart attack marker. It's a health condition that's typically associated with visceral fat. And the visceral fat, when that visceral fat increases interleukin. That interleukin-6 and visceral fat also. It is a health condition really associated with inflammation. And it's very common in pre-diabetics and diabetics. So for me, a diabetic is an inflammatory condition as well. So I wanted to put some numbers in. So high sensitive C-reactive protein, HSCRP. So below 1 is optimal. 1 to 3 is chronic inflammation and a risk for certain diseases. 3 to 10 is infection, injury, or other diseases. If you're over 10, man, serious systemic disease likely, such as autoimmune or cancer. So, we got to get our game together when we look at it that high. Most of my patients come in between a 1 and a 3. Occasionally, I'll see a 4 or 5. I don't see a lot of 10, 12, 14, things of that nature. Homocysteine, normal breakdown of proteins. Elevated levels are associated with a higher risk of dementia and heart disease. Let's share some of the numbers. Dementia risk is above 11. ASCVD is above 30. There are no symptoms typically with this until it's too late, so there's no precursors. And that's the problem with cardiovascular disease. At least half of it just happens without a symptom, which is spooky for somebody like me who tries to take relatively good care of themselves. Vitamins B6, B9, and B12 help detoxify homocysteine. Early detection and treatment are essential. I did not attack the methylation in this because when we were editing through the themes, we realized maybe the biggest rabbit hole would be methylation. So maybe at a later date, and I know that a lot of you already are very familiar with the idea of methylation. So MPO, myeloperoxidase, is an early indicator of patients' cardiovascular risk factors. The elevated MPO indicates the presence of unstable plaque in the artery. It can break away and move around, cause a stroke. HOMA-IR, it's an equation. I think this should be used so much more. It is so revealing because it marks for both the presence and the extent of insulin resistance that the patient may currently express. It's really looking at fasting blood sugar and responsive insulin. LP-PLA2 assesses the risk of stroke and CAD. It's essentially an enzyme that appears to play a role in inflammation of blood vessels. I usually see 1, 2, and 3 go together. So I usually see the trifecta, if you will. Cholesterol, I think cholesterol is been beaten up. You say the word cholesterol and most people go, oh, my mom was like, high cholesterol, it's 205. The doctor says I have to do this, I have to do that. I mean, I had many a moments with my mom and this concept of cholesterol. The real question is it a friend or a foe? I believe cholesterol's not really an issue. I think it's a misunderstood messenger. I think the only time cholesterol becomes a problem is when it has to start patching like a Band-Aid because of injury or excessive inflammation. Speaking of cell membranes, nutrients that it's made with. Cholesterol, again, to piggyback on what I just said, part of every cell membrane. Cholesterol is a precursor to steroid hormones, progesterone, bile acids, vitamin D. And again, cholesterol only appears to be problematic when oxidized. Insulin can switch HDL or excessive amount of insulin, and can change HDL to VLDL. Insulin also can stimulate the HMG CoA reductase, increase LDL. So when you think about cholesterol elevations and diet, about 15 to 20% increase if you consume a lot of cholesterol, but it would be a cholesterol across the board, and it would actually emphasize more HDL. Insulin would increase cholesterol markers by another 80 to 85%. So obviously, insulin being in a response to blood sugar, and that would be an increase in, as you see, VLDL and LDL. So obviously, if you want to lower your cholesterol, you want to lower your sugar intake. So it's essentially free radicals and oxidative stress. It is the oxidation of LDL. I'm just going to do something here for a brief moment, sorry. Which is now believed to be the focal point in the process of atherosclerosis. Preventing the oxidation of LDL may be the most powerful means of preventing cellular injury leading to atherosclerosis. I think this is a really cool slide because it really speaks to the idea of the interaction of dyslipidemia and oxidative stress and inflammation, which contributes to vascular disease. So the development of atherosclerosis, you see there's a tear in the artery wall. There's a fatty deposit in the vessel wall. Narrow artery becomes blocked by a blood clot. Essentially, inflammation occurs because of raised lipids. Atherosclerosis leads to endothelial dysfunction, and you've got oxidative stress and hypertension. You've got this cascade. You know, you light the fire as opposed to putting the fire out, you know, that fire being inflammation, they patch it, and they patch it with cholesterol. It becomes like a Band-Aid. Cholesterol is like the body's Band-Aid. When there's inflammation, it tries to patch things up. Status, the lower inflammation also acts as antioxidants. Glycemic dysregulation, glucose requirements, blood sugar spikes, insulin rushes to store excess. Cortisol, when insulin drops, hunger begins, insulin continues unopposed. So you've got this tremendous cyclical cycle. So if you eat too much or you eat too many sweets, your blood sugar will shoot up and then drop down precipitously. On the way down, your adrenals make cortisol to keep your blood sugar stable. So, you know, it's funny, before we got on, we were talking about cortisol in the little extra pouch in the belly. That little extra pouch in the belly can come from cortisol. It comes from eating sugar and taking the roller coaster ride of insulin and cholesterol via cortisol. So blood sugar levels, here you have a healthy blood sugar range. This is where many of our patients live. Remaining blood sugar from previous meal is absorbed into your bloodstream, causing a blood sugar spike. The pancreas pumps insulin into the blood in an attempt to bring blood sugar back to the proper range. Due to a high amount of sugar, pancreas overestimates how much insulin to pump into the blood. The end result really is too much sugar is removed from the blood, causing a blood sugar crash. Once again, up, down, up, down. Did you ever have a patient come in and say, I suffer from fatigue? Look at blood sugar. Did you have anybody come in and say, I have these highs and lows? Look at their blood sugar. So for instance, I've been sipping on water. I needed to sip some water because it seems like I have a little cough. Here goes something. Here is caffeinated organic coffee down the hatch. Let's see if this has a different effect on me. How triglycerides come from carbohydrates we consume. I really think that this circles the idea of sugar going to triglycerides. So the liver converts and stores carbs. Too many carbs consumed, and your liver becomes unable to eliminate, store, and process these carbohydrates. Excess carbs are converted to triglycerides, a fat in the blood, which in elevated levels can cause hardening of the arteries, poor circulation, and heart disease. So you'll see some protocols that I'm going to share with you. One of the protocols that I probably should have added is when you had dealing with somebody and have a cholesterol problem and you know they're eating a sugar-laden diet, you probably want to detox them as well. How sugar, not fat, essentially raises your cholesterol. Carbohydrate metabolism, healthy versus imbalanced. Carbs, glucose to blood, feeds to the cells, insulin activity. Excess carbs spills to your liver, gets made into cholesterol, body fat, and fat in the liver. Fructose is a nasty carb, so I like fruits. I don't like fructose. It is a sneaky carb because it goes to the gut. About 5 grams after fiber can get absorbed in the gut. The rest goes to the liver, cascading this problem. Watch your fructose intake. Advanced glycated end products. Typically, you have an elevated blood sugar. It binds to a protein in your blood known as albumin, which creates advanced glycated end products, or AGEs. What a great acronym in the world of longevity and anti-aging. The AGEs, advanced glycated end products, break down arteries and organs at an accelerated level. They're really more than markers of aging. They cause a tremendous negative biological effect on tissues and cells, causing free radical production and the increase of cytokines and inflammatory proteins. So really, people ask, what's the difference between type 1 and type 2? Well, type 2 diabetes is there is no response with insulin. Type 1 is there's no signal response. So in a nutshell, I took the quote, people who have type 1 diabetes are unable to produce the insulin signal. The cells of type 2 diabetics have lost the ability to respond to insulin. Glucose and hemoglobin A1C. This is a standard marker. Everybody should have this on every blood test. It's really fasting glucose is a snapshot in time. It's just there's a picture. Here's your blood sugar for today. What'd you eat yesterday? Pizza. Take a picture. What'd you eat yesterday? Avocado. 2 different markers. Hemoglobin A1C is a 90 to 120-day average, where 50% of the emphasis will be put on the last 30 days. Here's your numbers, but I didn't just do hemoglobin A1C. Obviously, 5.7 to 6.4 is pre-diabetic. It's preferable to have hemoglobin less than 5.7. Above 6.4, you're diabetic. However, you need to be 5.4 or less, because if you're at 5.4 or more, you're losing brain matter as we speak. But look at the typical correlation between fasting glucose less than 100 correlates to less than 5.7, 100 to 125 correlates to 5.7 to 6.4, 125 to above 6.4, etc. Another marker, HDL-C over triglycerides. 70% plaque-forming patients have insulin resistance. 90% insulin resistance patients actually go undiagnosed. This is a ratio that predicts the risk sooner than fasting glucose or hemoglobin A1C. And we have an ethnicity. There's difference between non-Hispanic, Black, Mexican American, and Caucasians. It is not that diabetes, heart disease, and obesity runs in your family. It's typically no one runs in your family. Again, we're going to be coming to the end of the lecture portion. Let's open it up for questions. Please populate the questions. I'll stay as long as you need to answer any of your questions. It doesn't have to be a question just pertaining to the subject matter. I'll open it up to some longevity questions, some gut questions, some sports questions, some lifestyle questions. I can't answer everything. You could ask some brain questions as well. But feel free to reach out. Like I said, that give and take is really where the salient points are really going to come from. So here's my Dr. Rob's blood sugar protocol. So number 1, low sugar diet, eat clean, GPS, DNA, IRS. What did I just say? GPS, no gluten. P, no ultra processed food. S, no added sugar. DNA, no dairy, no nicotine, no artificial sweeteners. IRS, inflammation reduction strategy. No processed seed oils. We don't have to discuss this. No processed seed oils and no deep fried foods. Alpha lipoic acid, great antioxidant that works with the water in the fat part of the cell. For glucose support, chromium, taurine, acetyl L-carnitine, EGCG green tea, berberine. Please, if you're going to take a probiotic, take a prebiotic, omega-3 fatty acids. And again, the dynamic duo, which I want to feature today, is vitamin D3 with K2. High homocysteine will really refer to the idea of a comprehensive formula supplying a biologically active form of folate, B vitamins, and NAC. NAC works great with upper respiratory issues, great for homocysteine, great for phase 1 and phase 2 of detoxification. If elevated blood lipids, add niacin, red yeast rice, phytosteroids, and a pre and probiotic. You can never go wrong by treating somebody's gut. So cholesterol, lipids, dyslipidemia, LDL elevation, niacin, omega-3, nattokinase, multivitamin, multimineral, red yeast rice, where you go again, vitamin D3 with K2, panathine, phytosterols, and we'll be doing something in September. I know they'll announce the date where we're going to be talking about the gut, my 7R action plan. I found it to be extraordinarily effective for people that have gut issues. Here's a natural way to lower your LP little a, your genetic heart attack marker, L-carnitine, coenzyme Q10, ginkgo biloba, resveratrol, curcumin, flax seeds, and of course, limit your carbohydrates. You could also add in vitamin D3 with K2. So let's talk about the dynamic duo. We are just at the bend. We're about ready to close up. So the dynamic duo is going to be vitamin D3 with K2. Vitamin D. I like vitamin D. It should be called hormone D. Vitamin D forms a swath of health promoting properties, running the gamut from musculoskeletal to immune health, also great for cardiovascular health. I don't know a more important test and not guess than your vitamin D levels, your appropriate levels. And I don't know a more important formulation or something that I actually utilize myself, my friends, my family, and sell in my office more than a D3K2 combination. D3 is great for kidneys, pancreatic function, helps with the placenta, lungs, colon, skin, prostate, and helps keep anti-inflammatory macro. K2. So I'm going to say it now. In the next 3 to 5 years, vitamin K2 will be what vitamin D3 is. So vitamin K2 decreases amyloid-induced apoptosis, has a tremendous antioxidant effect. It increases the master antioxidant glutathione. It decreases neuroinflammation, decreases levels of interleukin 6, interleukin 1 beta, and TNF alpha, suppresses the NF-kappa B pathway, two main inflammatory pathways in the body. It has roles in other neurodegenerative diseases. K2 levels are inversely associated with the progression of Parkinson's disease and frequently of MS attacks. It helps rescue mitochondrial function, increases ATP production. A look behind the curtain, all your neurodegenerative diseases start with the gut, and they are mitochondrial functions. One of the top, or you could say the top mitochondrial organ is your heart. Number 2 would be your brain. Improves vascular health. K2 decreases arterial calcification and improves endothelial function and could link the microbiome with Alzheimer's. Microbiome disruption lowers K2. Intestinal K2 is associated with cognition. D3 with K2 enhancing health. So people say, why do you have to have K with vitamin D? Well, the end result is the overview is if you take K with vitamin D, when it mixes with calcium, will take calcium to the bone and not the soft tissue, the plaque. So let's go through the slides. Enhanced calcium metabolism, optimal CA utilization, bone health and density, strengthening the bones, cardiovascular health, promoting health, heart function, and blood pressure regulation, improving muscle function by enhancing muscle strength, better coordination and balance, and improving mental health, supporting mental well-being and cognitive function enhancement. So here's a simplified overview of potential synergy between vitamins D and K in bone and cardiovascular health. So here's vitamin D having a mix with optimum K, leading to an improvement, and the end result is a decreased fracture risk, a decreased vascular calcification, soft tissue calcification down, and bone mass density increase. So again, vitamin D3 with K2 is the choice. So realistically, looking at bone health and cardiovascular, it's a bidirectional circuit, and this slide does it best. Number 1, vitamin D3 with the mix of K2 stimulates osteoblasts, bone laying down to produce an inactive osteoclastin. Number 2, K2 is unable to put calcium on the bone. It activates calcium to give calcium to the bone. Stimulating matrix glial protein MGP stays inactive, risks arterial calcification, ultimately activates MGP, direct calcium to the bone. So you have to have this combination. As I said before, vitamin D3 on its own will take calcium to the soft tissue. So D3 and K2, calcium's personal relay. Calcium supplementation has been a source of concern for many researchers and physicians. Vitamin K2 deficiency could be responsible for the so-called calcium paradox, that is the lack of calcium in a bone and its storage in the vessel wall. These events may have clinically relevant consequences such as cardiovascular disease and bone fractures. So vitamin D plus calcium leads to the idea from Jerry Maguire, Renee Zellweger with Tom Cruise, the man who never ages, you complete me. So here's the formula that we're talking about. I know we'll discuss this more in detail during the Q&A. It has the most bioavailable, natural, and long-lasting form of K. The form of K that we're talking about is MK7. That is produced from the natural fermentation in the most biologically active, bioavailable form of MK7. The half-life of MK7 is 48 to 72 hours. MK4 is only 4 to 7 hours. So therefore, synthetic fermentation of K2 yield many forms of K2 that have not been studied for safety or efficacy. One needs to be very careful. MK7 is the choice. Here is your dynamic duo, your superstar formulation, vitamin D, 5,000 IUs with K2, 200 MCQs. So let's get a little granular. Vitamin D3 is ethically sourced from lanolin, microencapsulated. It's kosher. Vitamin K2 is considered gold standard of K27, high stability and bioavailability, produced from fermented chickpeas, 100% soy-free, backed by 23 research studies, 100% natural K27, trans isomer of MK7, only a form that is biologically significant. Jim Rome once said, take care of your body. It's the only place you have to live. We got to the questions in just under the hour, so we're probably at the top of the hour. Let's go, and feel free not to only ask the questions, but to ask questions other than what we discussed.
Great. Thank you so much. That was perfect timing. And I've been gathering the questions for you, both from the chat and the Q&A box. So if you are ready, we will just dive into those. And we'll just go in the order of kind of how they came in. So you spoke at the beginning of your presentation about intermittent fasting and just the different recommendations for men versus women when it comes to intermittent fasting. So one, would you, just if anybody missed it, if you joined us late, can you repeat the fasting recommendations for women depending on where they are in the month? And then in addition to that, do you have recommendations for after menopause at, say 57 years old, what the fasting window would be for those women?
Absolutely. So let's take a step back. If you're a man, you can intermittent fast from 12 to 16 up to 18 hours. I don't like a lot of 3-day fasts. You can do it once a month. I'm not big on people doing it every week because if muscle mass is the longevity organ, you're not getting nutrients for periods of time. So I have not seen the great outcomes. This is for healthy people. We're not talking about somebody like, let's say, with cancer. So the men, you press the button and they can intermittent fast. I happen to do about 14 hours of an intermittent fast, which leaves me 10 hours of eating. I prefer it that way. 16 to 8, little strenuous for me. 18 and 6, though there's data for it. Just not a big fan. Wouldn't go any further than that. 20 and 4, you're eating one meal a day. I know Mark Warburg does it on Instagram. Congratulations. But, I don't believe everything that occurs on Instagram because I am on Instagram, so I get it. So for the women of menstruating years, where their estrogen turns over to progesterone on day 14 or 15, progesterone again needs to be high because it's a calming hormone for women. When they're stressed, the progesterone drops down, and then when it drops down, they get a lot of PMS issues and they feel stressed, etc. I tell my wife that if she intermittent fasts too much during that last 7 days of her traditional, if you will, 28-day cycle, if there's such a thing anymore, she turns a little into like the Tasmanian devil, if you will. So for women, the first 2 weeks, I would suggest of the month, I would suggest intermittent fast for 16 hours. Week 3, knock it down to 14 hours of fasting. And week 4, knock it down to 12. You can simply get to 12 hours by just not eating the first hour when you wake up, and don't eat 3 hours before you go to sleep. We should all probably avoid eating 3 hours before we go to sleep when you think about it. If we did that, we'd be eating in a healthy time frame. We'd be synced with our circadian rhythm as well.
Someone was asking about, so a couple of things. One, do you have specific treatments or recommendations for ApoB if present? And then also kind of along in that same vein of just interventions for like a high LP little a. Would you have recommendations for either of those that are more specific?
Let's go back to what we talked about. Sorry. Rule is you're never supposed to go backwards in a slide deck. I just broke the rule. So there's LP little a. So I've got the 1, 2, 5. Really, flax seeds and limiting carbs are meals. So I think if you do those are golden. Those are easy. They're not sexy and anything of that nature. ApoB really falls under the category of the LDL. I just picked LDL. I probably should have highlighted ApoB. One common denominator in both of these would be vitamin D3 with K2. Really to speak to that, it's the number one seller in the office, and it's probably the number one seller in most people's supplement lines. A very close second is probably omega-3 fatty acids. And probably the only thing that would surpass that would be something with the gut, like a probiotic, but it wouldn't be any one probiotic because you got spores, and now Akkermansia is real popular, like the Bacillus acidophilus. So if you take a look at the niacin, the omega-3s, nattokinase, red yeast rice, vitamin D3 with K2 in your diet, I think you'll be doing really, really well. One little side about omega-3 fatty acids. You should take your omega-3 fatty acids, and I hope I don't dive into a pool of questions with this. I would add pro-resolving mediators to do that. They allow for the resolution of inflammation. They're a great hack to decrease inflammation. I had Dale Bredesen on my podcast, and he spoke about them very favorably as well.
Yeah. We love SPMs too. What is a good calcium score? What do you want your patients to be at?
Whatever you know, 0. That's unrealistic, but 0.
Yeah. Low as possible.
As low as possible would be the answer.
Yes.
I mean, the real question is at what number would you go on a statin is probably the question. And since we don't give medical advice, as long as it's really low, you're good. Look, we're all going to plaque. I mean, there's just a couple of my friends at 58 to 60 that have zeros, just a few. We're talking a very small percentage, so it happens. It's not the end of the world. It doesn't mean that you're going to terminate. Just means that you need to do certain things. And just remember, the plaquing is coming from either chronic or incidental inflammation, because cholesterol is a Band-Aid. It patches up injuries. Cholesterol is like amyloid in the brain. It's not the amyloid that causes Alzheimer's. It's what causes the need for amyloid to plaque and the tau tangles to unfold in the mitochondria. And we'll probably be here for 2 hours now. I said it.
Yeah. What are your thoughts on resistant starches? This person here,
Love it.
Health professionals saying you can eat as much as you want and it will not affect blood sugar.
I always get scared when you can eat something as much as you want, like it's ubiquitous. I think that if you're going to have a starch, a resistant starch is a great choice. They're quite tasty. I think if we're going to have rice, I think it's called parabone rice. So I think if you have these type of starches in that form, you can still enjoy them as long as they're positioned in a meal. So for instance, if we're going to have rice, and it's a resistance rice, we're going to definitely eat it after some protein, some avocado, and some vegetables.
Yeah, yeah, resistant starch is great for the gut too. And when you heat and then you let it
Cool.
cool, and then when you reheat it and let it cool, so the more reheating and cooling cycles, the higher the resistant starch content gets, and so you can actually increase the resistant starch
Absolutely.
in the
The
in
data I read about the resistant starch was once you made it a resistant starch, it never goes back to a regular starch. And piggybacking on what you just said, you can actually make it more resistance, which will be obviously, as you said, more beneficial for gut health.
Mhm. Many health influencers are recommending 1 gram of protein per pound of body weight or goal weight. Do you agree?
Yep, for both men and women. Yes, it is the miracle macronutrient. Um, I would agree with that. I definitely would agree with that. So to speak to that, so say you have a 150-pound female. How are you going to get 150 pounds of protein in one meal? What is she going to eat? Like half a horse? You have a 200-pound male. How is he going to get 200 grams in one meal? That's a lot. Well, how much ribeye is he going to go for? So that's why you kind of want to spread it out, and you should have protein at every meal, because protein, you want that ingestion, and it also decreases the glycemic response. So the answer to your question is yes. We need more protein as we age than we did when we are younger, and we don't absorb it as well, and there's more of a need. And again, I think we talked about the animal versus the plant and how we can make the plant more um, higher in muscle protein synthesis and availability.
You talked about niacin. Do you have a dose that you recommend for niacin?
I'm gonna have to look it up because there's doses I remember, and niacin is a dose that I won't remember, and I may say something wrong. I apologize. So, for instance, typically D3 is 5,000 I use typically. Omega-3 fatty acids is anywhere from 2 to 4 grams. I usually like things in the billions in probiotics, et cetera, et cetera. I'd have to look and get back to you on that. Sorry.
It's
Let's
okay.
want to bail me out.
What about NAC enhancing cancer risk? Do you have any thoughts about that?
I like NAC. Um, I don't know if I necessarily agree with a few of those studies. I do take L, liposomal glutathione, before NAC because it is the master antioxidant. I do take astaxanthin, but I think NAC is very health promoting, and at this point I wouldn't concern myself with it. It's an interesting thing, and it's great that we talk about studies, both that are positive and negative, but you got to look at the risk reward and you got to look at the scale. So, the risk reward is, when would you take an antibiotic? Well, if I had meningitis, I'd certainly take an antibiotic. If I had a staph infection, I certainly would take an antibiotic. The risk reward, how is one idea, but the scale is the other. How much weight to the articles? Like, where do you go? Which is the tipping point? And how is it just a little over the top for a tipping point, or is it really weighted in one area? I would say right now, the weight in the area is that NAC is to go for it.
This question came in based on one of your answers you were talking about with the protein. So how much leucine should be taken for a plant-based protein diet?
2.5 to 3.5 grams per plant meal.
Okay, perfect. Let's see here. Just knocking out these questions. Um, do you have thoughts on testing for vitamin K2? Any thoughts on, do you test for K2 in your practice, or do you have any thoughts about around that?
I test for D levels in my office because I'm able to do it with a finger spot. The K levels I usually do with the serum testing.
Mhm. Yeah, and there's a couple tests on the market that, yeah, you can look at intracellular, but one of the things with K2 is it's not readily available. There's not like a great way to test for K2 like some of your other vitamins. In the research, there is a inactivated matrix GLA protein test that can be done. It's not widely available. So it's not really practical for us in clinical practice to test for K2. So there's not a great way. However, we can also look at for us humans, one of them in the westernized culture, the main way that we get K2 is through our microbiome and microbiome K2 production. So on tests like Biome Effects, we can look at that function of our microbiome and if it's making enough K2. And again, it's not going to tell us the exact levels, but it'll tell us if that person is making enough of that K2. Because unless you're eating, natto or fermented fish from Norway and putrefied cheeses, which most of us in westernized cultures aren't, some of us might be, depending on your cultural preference. But there's not a lot of vastly available food sources of K2, so we have to rely on it from our microbiome for the most part. But I do know I was researching this for a presentation a while back and came across the inactivated matrix GLA protein. But like I said, there's not a testing company that really does that's readily available for us. Let's see. We have a few sort of case questions. And again, we always have to be careful with, patient questions because this is not medical advice. We're not advising you on what to do with your patient necessarily because we don't have that whole history. But if you have some thoughts for this person, they're asking about a protocol for someone who has extreme fatigue, brain fog, difficulty with weight loss, has a history of PCOS, postmenopausal, and positive for mold toxicity. Maybe just quick thoughts for this person.
Well, obviously they have a lot going on. That's obvious. Obviously, their diet would be a major issue. I would definitely test for food sensitivities. I would test for a leaky gut panel. I would adhere to my 7R program, which I think we're going to learn all about in September, correct? I think it's September. Am I saying the right date?
Yep.
And I would fix up that gut because I believe the gut is the epicenter of your health with 80% of your immune cells in your gut. That's without question a place to start. And the idea of neuroception in your gut, where your enteric nervous system, which is the largest nervous system in the body, lines your gut and communicates with your vagus nerve, where you have that gut feeling or female intuition, where you are able to understand or have a sensation of unconsciously safety and danger. I think that you can never go wrong when you have a myriad of things happening and attacking the gut specifically.
Yeah. Going back to just the protein and fasting questions, we're getting a lot of questions around that. So this person is asking, in protein absorption studies in humans shows a time ratio generally about 3 to 4 hour windows in relationship to individual lifestyle and activity. What is your recommendation on fasting versus protein intake?
I guess they're asking me, do I believe to the window is every 3 hours for 30 grams?
I think so. I think that's what they're asking.
I would love to see the data other than the one that Myoplex and Metrics put out. So interesting. I do believe that at every meal we should have some protein. And obviously I wouldn't have my meals every 2 hours. I'd rather have them every 3 or 4 hours spread out. That's why I have a 10-hour window. So I eat with hour 2, I eat again in hour 6, and I eat again in hour 10. So I have my 3 hearty meals in that time frame, in that 10-hour time frame. If I need a snack in between, it just means I probably haven't eaten a lot, or like yesterday where I did a little extra, my body's like, give me something. So that would be number one. Number two, as far as having to eat after exercise, that may be sort of tied in a theme there. There's a study that came out that if you eat 25 to 100 grams of protein, you have a 12-hour window of your muscle protein synthesis that is open. So somebody like me who likes to lift at night, because in the morning he actually does, I get up in the morning to do work overseas because I have patients and stuff in the UK, etc. So I have to lift weights at night and I don't want to eat after I lift. That study made me feel very comfortable with the idea that you do not have to eat right after, as long as you've eaten a large amount of protein before. So hopefully that answers the question.
Mhm. A couple of questions on just dosing. So someone's asking about the safety levels of supplementing with vitamin K2. If which I can also help with that question because if you haven't watched, we did a webinar in April going over just a lot of foundational information around vitamin D and K2. Vitamin K2 there is no upper limit established for K2. There's not really even any kind of like a DRI around K2 specifically. Our adequate intake is what we have, and that encompasses K2 and K1. Vitamin K2, though, itself has a very good safety record. There have been safety studies done and toxicity studies done, and getting to extremely high levels, in the millions of micrograms. So it's actually quite safe. So supplementing, in fact, in like perimenopausal women and postmenopausal women for cardiovascular health and heart health, dosing of K2 around even up to 360. There's even been studies done for coronary calcium up at 720 micrograms of K2. So you can go pretty high with K2, and it's very safe. So hopefully that answers that dosing question. Um, Now, for you with vitamin D, if a vitamin D level is around 60, would you recommend supplementing with just K2, or where do you like people to hover with their vitamin D levels?
60 to 80 is a great number to be. I have no problem with 80 to 100. So maybe 2000 IUs if they're not supplementing to get there. It's fine. I had a patient, now when I say I had a patient, I had nothing to do with the patient at the time. She's an older woman, maybe 120 pounds. She had a vitamin D score of 213, my all-time record of viewing somebody. Because normal, I mean, I see more 13 than 213s. Wouldn't you agree? And so obviously, when she had her test, the functional medicine doc that she was using at the time said, I think you need to cut back on the dosage. And she went down to 72, and that's when she came in my office. It wasn't for the vitamin D, it was for something else, a bunch of things. And I said, hey, 72, that's really good. What are you dosing? And she said, I haven't taken a vitamin D pill because I was taking, 25 to 50,000 IUs a day. I don't know who told her to do that. I didn't want to go down that because that was, wow.
It's a lot.
Right. And she had no symptomology, about 70 years old at the time, from high vitamin D. I had another patient that was taking 5 times the prescribed amount and he had 133 and he was getting some side effects from vitamin D, which you're not supposed to get. Really safe between 140 and 200. You may see something. Um, so 80 is a good number. If they're at 60, I would give them 2000 IU and retest. And that really brings to the point, everybody should probably be testing for vitamin D on every blood serum test and maybe even have a finger spot so you can test real quick every 3 to 6 months. Because how do you determine how much to give? You brought up a really good point, and that goes back to the idea of the webinar, testing and not guessing.
Yeah, exactly. Yeah, you definitely with vitamin D, it's very highly individualized. You can have some people, and again, like you mentioned, it's a hormone. So just as with hormones, you want to make sure that you're checking and testing and you're not guessing with it. So everyone's going to react sometimes a little bit differently. There's lots of different variables with vitamin D, and all of that is covered in the webinar that was from April 9th. So definitely take a look at that because your age, your skin, whether you're overweight or obese, the amount of fat that somebody has on their body, their latitude of where they live. There's many, many factors that go into a vitamin D level and what people's levels are going to be. So, okay, great. Let's see. So I think we covered probably, looking at the time, maybe just one more question. Going back to the protein discussion. So creatine has become a mainstream lately, and especially for brain health. And if someone's eating a gram of protein per day, would taking creatine be excessive?
I have an affinity for creatine. 26 years ago, we were the first chiropractic school that had to write a thesis, and I wrote my thesis on creatine. So the update on the creatine is yes, good for both men and women, excellent for muscle development, great for short and long-term amnesia and a concussion, excellent for cognition, better for women in cognition than men. You don't need to preload. So your 5 grams a day is more than sufficient.
Good. Well, thank you all for coming. I'm going to real quickly put up a slide on our upcoming educational opportunities. We have June 18th, our next and final installment of the mini keynote series on cardiometabolic health with Jenny Olson, one of our clinical science liaisons. And then on the 25th of June, we have a little bit of a switch in gears going to women's health and fertility. So I'll be talking with Dr. Liz Bartman, who's a naturopath. We'll be going through the fertility formula and discussing all things preconception and fertility focused for women. So definitely check out the registration links for those 2 talks that are coming up in June. And thank you all for hanging in with us. And we hope that you enjoyed this presentation, and we look forward to supporting you in our future education. Thanks so much, everyone.
Hello, hello.